And thanks for the opportunity to be with you and to share the results of the OPTIMUM study. The OPTIMUM study was a prospective investigator-initiated study of 750 patients with complex coronary artery disease, that is left main or multivessel coronary artery disease, who were deemed ineligible by the site-specific heart team, specifically the site cardiothoracic surgeon, to be ineligible for coronary artery bypass surgery. The study was performed at 22 centers in the United States, and we examined the outcomes of patients undergoing high-risk PCI after determination of ineligibility for bypass surgery. Specifically, we compared the actual or observed mortality, either in hospital or through 30 days, with that predicted by surgical risk models of the STS, the Society of Thoracic Surgery risk model. But as secondary objectives, we also compared the actual mortality with the Euroscore 2 model and also the site surgeon's own estimate or prediction of mortality by 30 days. And as a key secondary objective, we also examined patient-reported health status measured by the Seattle Angina Questionnaire and the Kansas City Cardiomyopathy Score. In other words, we examined quality of life, patient-reported angina status, and heart failure symptoms. So this is a terrific question because, just as a background, these patients with complex coronary disease are of increasing prevalence across the world in cardiac catheterization laboratories. It's estimated that patients with complex coronary disease, left main or multivessel disease, who are not eligible for bypass surgery represent at least 1 in 5 such patients. And these are patients who are not routinely addressed in societal guidelines. They're not included in clinical trials. So we really don't have much information with regard to the outcomes, especially with contemporary PCI. And the purpose of this study was to not only characterize this population, but secondly, to examine reasons for why the patients were turned down for bypass surgery. And then perhaps most importantly, to examine the clinical outcomes with high-risk PCI and to provide information that would help guide decision-making for these patients in the future with regard to whether they should undergo PCI or not versus medical therapy alone, perhaps. And secondly, to determine what benefits could be observed with PCI, not only with regard to survival, but with regard to health status. And finally, to help inform estimates or shared decision-making with patients and their family to be able to provide them an estimate of what the likelihood or the prediction of adverse outcomes would be in this specific patient population. So certainly for patients, we know from randomized clinical trials that are quite dated in the medical literature. For example, for left main disease, we know that bypass surgery is a life-saving endeavor. We certainly know now from a succession now of comparative trials of PCI versus bypass surgery that there are selected instances in severe disease burden where bypass surgery may have an advantage, especially with regard to non-fatal myocardial infarction compared with percutaneous revascularization. There are some studies, for example, in diabetics suggesting the advantage with regard to survival of bypass surgery over PCI, again, at least in selected patients. But here, these are patients who are determined by the surgeons to not be eligible for bypass surgery. And so we don't have good information with regard to the outcomes when surgery is not an option, and that was the purpose of the study. We have a wealth of information from this study. The first key finding was that the mortality rate of 5.6%, which is certainly higher than other contemporary studies of less complex patients, was actually predicted uniquely well with the surgical risk models. And it was 40% lower than that predicted by the site surgeon's estimates. We also observed significant improvements in patient-reported health status, quality of life, physical function, angina frequency, all significantly improved with percutaneous revascularization. And in fact, by 6 months, more than 80% of the patients were free of angina by their own report. So as next steps, we're going to further dive into this wealth of information from this trial to, for example, determine risk models or models to help inform decision-making with regard to which patients do benefit, how much completeness of revascularization is needed to improve both outcome and improve health status. And moreover, to provide information to patients that we can share with them when surgery is not an option so that they can make an informed decision with regard to either medical therapy alone or PCI with medical therapy.